Thanks, Julia. Thanks, everybody, for joining us today. We have talked about Candida auris in some of our previous grand rounds. This continues to grow, so I thought it was time to revisit. And my goal today is to really talk about the difference between C. auris and other types of Candida, the challenges with treating a C. auris infection, the risk factors, and then what we can do as far as infection prevention and control to limit transmission and limit infections and outbreaks. So we see Candida infections really pretty often in healthcare. Now, Candida albicans is what we typically see. That's one of the things we see the most commonly. Now, Candida albicans lives in the gut, but it can live on the skin as well. And in some cases, especially if we have skin that is moist or frequently wet, we can have infection. So this can be in skin folds, on our feet, in the diaper area. Sometimes it can be in the vaginal canal or in the mouth. Now, most of the time, this is really easily treated. If we're at home, this can be treated with over-the-counter prescriptions, or I'm sorry, over-the-counter medications most of the time. Sometimes people will need a prescription medication, but we see it all the time. So something when we hear about someone having Candida, we're not always alarmed by hearing that. Now, I will say that Candida albicans is, if it becomes an invasive illness, it can, cause serious illness. But Candida albicans isn't really associated with outbreaks. We don't hear about outbreaks of,
Thank you for my gift.
or outbreaks of um, athlete's foot. So C. auris is similar to Candida. It's much, much hardier, and it is associated with outbreaks. It can live in the GI tract, but it's mostly found on the skin, and it is really tough to kill. We first identified this in 2009. It was probably around 10 or 15 years before that. At the time, the testing was just limited. So a lot of times we would, the lab would identify Candida, but it would be misidentified as a different type of fungal pathogen. Now, our testing has improved. So we were able to identify it much more accurately now. And we don't know, why it came to be. We found this, it kind of came, we started in Japan. It quickly spread across the world. And I think it's been, pretty much everywhere. There's a lot of factors that went into probably the development of C. auris, including the warmer temperatures, global migration, people living in crowded environments, and then also the increased use of antifungals in agriculture and in healthcare. We know that when we have orchards and things and we spray antifungals on them for the health of the fruit and or the food, that the yeast in the environment becomes resistant. So there's probably lots of factors that played into this. Now, I've mentioned we first identified it in 2009, but now it's really everywhere. And it is considered an urgent public health threat by the CDC. The reason is that 90% are resistant to one class of antifungal and 30% are resistant to two classes. 5 to 10% of people that are colonized with C. auris will develop a C. auris bloodstream infection within a year. And with that invasive infection, the death rate for that is between 30 and 60%. And I thought this showed how quickly it spreads. Now, we don't have really high numbers the way we do when we have the flu and things like that. But you can see in 2017 on the left, many states had no cases at all. And no state had more than 100. And then you look at 2022 on the right, and it has absolutely spread. And we have many more states that have had 500 or more cases. Now, I mentioned this is considered an urgent threat. The graph on the right shows the increase in cases between 2015 and 2018. So it just has steadily increased since first being identified in the United States. Now, when we think about treating a fungal infection, we have three groups of medications, three classes of medication. So the azoles are things like fluconazole, ketoconazole, clotrimazole, echinocandins, which are things like micafungin and capsifungin, and then amphotericin B. All three of these work differently, but they all work by attacking or interfering with the fungal cell wall or cell membrane. And that fungus can develop resistance pretty quickly. And there's several types of resistance that they can develop. And I'm not going to talk about much, but I will talk about biofilms. We know about biofilms, especially when we are talking about a patient with an indwelling device of some kind, that biofilms can form on that, and it makes it difficult to treat any sort of infection. C. auris can also make biofilms. And what this does is it creates a layer of infection that is really great for C. auris because it can continue to reproduce. But it makes it very difficult for the medication to penetrate. So it makes it really tough to treat a patient when a biofilm has developed. So if you have, a central line or indwelling catheter or something like that, and there is an infection, most of the time we have those removed because it's going to be tough to treat effectively when we have a device in the body with that biofilm. Now, biofilms, like from C. auris, can also form on surfaces. So if we have this on a surface, they can form a biofilm, and that's what leads to the persistence in the healthcare environment. And I wanted to show this. This is two independent clusters of pan-resistant strains that were in Washington, D.C. and Texas. And again, not huge numbers of patients, but you can see from the first 2017, we had resistance to one strain. And as every year we have more cases, we have more resistance to one strain, and those red lines show, or the red bars show, resistant to all three classes. Now, there are some risk factors that put patients at higher risk for developing C. auris. So having an invasive or indwelling device, someone who has recently or currently receives complex or high acuity care, folks who need frequent or long healthcare stays, people that are colonized or infected with another MDRO, those who use mechanical ventilation, recent use of broad spectrum antibiotics or systemic antifungals, history of transplant, older age, underlying medical conditions, recent surgery, and wounds. There was a study done by the New York Department of Public Health in 2016 that lasted a few years. They did point prevalence surveys among residents of skilled nursing facilities that were ventilator dependent, or sorry, ventilator capable. They did this at 6 facilities, and they had 218 controls. 60 of these patients were colonized. And they looked at the risk factors, and you can see that a patient being on a ventilator and a patient that had received systemic fluconazole in the past 90 days had a pretty high risk. The adjusted odds ratio was about 6 for both of those. So that put patients at a much higher risk of developing or acquiring C. auris. There was also an increased risk for those who had received carbapenem antibiotics in the past 90 days and those who had been at an acute care hospital at least once in the previous 6 months. Now, in 2021, we had our first case of C. auris in Kentucky. And the Kentucky Department for Public Health put out some screening recommendations about who to test. And they recommended screening for patients who were presenting from a long-term care facility, a SNF, or a rehab facility who in the past 12 months had an MDRO, had used mechanical ventilation or had a trach, had chronic or had chronic unhealing wounds. They also recommended screening for any patient who had been hospitalized outside of the U.S. in the previous 12 months. Residents who had come from central or southern Indiana or southern Ohio who had extended stays in healthcare facilities, whether acute or long-term, should be screened. And then residents of any other state that had high incidence of C. auris who had also had extended stays in healthcare facilities. And when you think about testing and screening, you have to decide how you're going to do that. What does that look like? So you can have prevention-based screenings, and this would include something like screening every patient or resident when they're admitted, testing them periodically during their stay, and any discharge or transfer you'd want to test. Or you can screen those that just have high risk of colonization. So those would be people who had been exposed to shared medical equipment with a patient who had CRS, facilities that have current cases of CRS, patients that have risk factors, or someone that has shared a room or care area with someone with CRS. We had a discussion last week with someone that works at a long-term care facility in Kentucky, and she said when a patient comes from another hospital, their protocol is that the patient is screened and is placed in isolation until those results come back. So facilities may have differing protocols on how to test and when to test, what to do. So you'll see that, is not going to be the same everywhere. Now, I mentioned that CRS specifically is pretty difficult to diagnose. So Candida will grow on a culture plate, but then from there, it's difficult to determine what type of Candida. And then using phenotyping kind of can misidentify CRS as another pathogen. So right now, the best way to identify CRS is using MALDI. I know that Dr. Alan Junkins has given presentations in the past about MALDI, specifically how it works. And so it will work by smashing up the molecules and then weighing the proteins. Now, any CRS that's identified is sent off to our state lab for testing. It's also a reportable disease, which I'll talk about in just a moment. The problem here is that MALDI is pretty expensive, and not every lab has access to MALDI. Now, when we've identified a patient with a Candida auris infection, we need to make sure that the infectious diseases team is involved, that we don't treat colonization. So this would be for infection. So in the US, the initial treatment is with echinocandins, but once we get sensitivity, we may transition to an azole. Patients with an infection should have a dilated eye exam within 1 week. What we typically are going to do is repeat blood cultures until negative and then continue for 2 weeks or longer after that first negative culture. And then the patients have to be monitored while receiving the treatment because some of those antifungals can have some significant side effects. And as you can imagine, pan-resistant infections are really difficult to treat. We often need the help of several specialists to try to come up with a plan to treat these folks. As I mentioned before, if the patient has an indwelling device and we think that's the source, we should have that removed. So if it's a central line, a PIC, something like that, we want to have that removed as soon as possible. Once treatment's done, it could be replaced. For those who have an artificial heart valve, again, that should be replaced. That's not always able to happen. And so for those patients may require chronic suppressive therapy. Again, the same thing with pacemakers and cardiac defibrillators should be removed. If they can't, they're going to require extended therapy. If we feel like this is in a bone, it's going to require a longer course of therapy and it may require surgery. And then if we have a prosthetic device like a knee or something like that, again, we should remove that or this patient's going to require chronic therapy. When we think about outcomes, what's the outcome from someone that has this? So this was a study that looked at 3 New York hospitals, and they divided patients with Candida bloodstream infections, and the other group was other Candida bloodstream infections. Now, the mortality between these groups was the same, but the 60-day recurrence was about 12% in the CRS group versus 4% in the other Candida group. And those who had a CRS bloodstream infection had 60% of the time had a previous MDRO compared to 11.5% of those who had other Candida bloodstream infections. And there was also a retrospective study done at a hospital in Pakistan, and they compared those same 2 groups, those who had a CRS bloodstream infection versus patients who had a different type of Candida bloodstream infection. And you can see kind of the differences here. The CRS patients had an increased risk of mortality. The stay was double that for the patients that had CRS. the CRS patients had almost 30% were resistant to voriconazole, whereas the other Candida infections had no resistance. And 3.7% of those CRS bloodstream infections were resistant to amphotericin. They also looked at the use of antifungals in the previous 90 days and found that the odds ratio was 38. Now, I mentioned there's no decolonization that we can do for patients that are colonized. We have tried some different things. They've done some studies looking at using chlorhexidine bathing at 2%. It wasn't effective. And then doubling that to 4%, which did not really show any significant decrease in colonization. So right now there's no prophylaxis recommendations, and there's not really anything we can do for decolonization. I do point out that chlorhexidine bathing does have a role in decolonization for things like pre-surgery and things like that, but it's just not effective at getting rid of CRS. Now, within an acute care hospital, those patients were going to be in at minimum contact isolation. We're going to make sure that hand hygiene is performed during any patient care and before and after putting on PPE. If possible, this patient will be in a private room and using dedicated equipment, again, if possible. If it's not possible, we want to make sure that we are carefully cleaning any shared equipment with the appropriate type of disinfection wipes. And if the patient has to share a room, we want to make sure that they're separated as much as possible. We want a curtain in place, and we have to treat this almost like two different rooms. So if we go in and treat one patient, we want to perform hand hygiene and change PPE before we go to the other side of the room and see the other patient. We also, if EVS is in the room, we want to have them clean, change their mop heads between these spaces as well. Now, outside of acute care, staff should be using, at minimum, enhanced barrier precautions for patients that have CRS. And so in that case, they're going to put on gown and gloves prior to any high contact care. So that's going to be like things like dressing, bathing, toileting, assisting with hygiene, changing linens, and then any care, the wound care or device care. And this just shows us kind of the difference in its types of PPE that's needed. So on standard precautions, we only use PPE if we are going to be exposed to something like contaminated equipment or blood or body fluids. With contact precautions, we're going to put at minimum gown and gloves on before we enter the room, and we're going to keep that on the entire time. With enhanced barrier precautions, we're going to use, again, at minimum gown and gloves, and we're going to just wear that during that high contact patient care. Environmental cleaning becomes really important because CRS can live for a very, very long time in the healthcare environment. We typically use a quaternary ammonium disinfectant, but that is not effective against CRS. So we need to use an appropriate disinfectant, which will be chlorine-based or hydrogen peroxide-based. And we want these rooms to be cleaned every day. Again, focusing on that high-touch surfaces in the area around the patient. We want to make sure we have terminal cleaning when the patient is discharged or is transferred. Cleaning and disinfecting any shared equipment used by that patient before we use it with another patient. And one thing that's really important here is make sure that we have communicated who is responsible for cleaning that shared device. If we don't have someone responsible for it, it doesn't get done because people think someone else will do it. So we need to make sure that that is very clear with everyone. Is it going to be the person who just used the device? Will it be EVS? Is it going to be an assistant on the unit? Make sure that we know who's cleaning it and so that it gets done. And then if this patient's moving about, we want to also clean any other area. So if they are going to physical therapy or they're going to radiology, we want to make sure we're cleaning those areas, again, with the appropriate disinfectant. This is just a screenshot of the list P. This is the EPA's registered products that are effective against CRS. And you can see it tells the active ingredient here and the contact time, which becomes really important because this is the time that the surface needs to be wet in order to adequately be effective. Now, there are some things we can use Additionally, so ultraviolet light robots, they have high intensity radiation that will destroy the DNA and kill CRS. And then ultrasonic machines that aerosolize submicron particles, and that will clean up everything in the room too. These, again, would be just used in addition to what we would already be doing. Not many people have these because they're pretty expensive. We also want to make sure that if we have patients being transferred between units or between facilities, that receiving staff are aware of the patient's status. Now, this is an example of CDC's interfacility transfer communication form, but there are others that can be used. And it just is a good way to communicate this patient's colonization or MDRO history with the receiving facility. I mentioned that CRS, both colonization and infection, are reportable. This has to be reported to the Kentucky Department for Public Health within 1 business day. The lab will submit some paperwork and an isolate to the state lab, and then whatever facility ordered this, so if it's going to be, something that was ordered at a hospital, if it was ordered at the long-term care facility, those folks will need to submit some further paperwork. This is an example of the reportable MDRO form. This can be done online, but it gives you an example of the kind of information it's asking. And this is information that the lab is not going to have all access to all of this. So it will ask for demographics, the type of MDRO, whether the patient required hospitalization, and further information. Now, again, this will be reported to the Department for Public Health, and they'll work closely with the facility to determine what to do next. So they'll help us decide if a point prevalence survey is necessary, and if so, who should we test? Do we test everyone in the unit? Do we test everyone in the department? Do we test particular patients? And then based on those initial screening tests, we may do further testing, but they will help us and guide us the entire way. And they will help get supplies to us and make sure that we know where to send it and all that kind of stuff. So they'll partner with us the whole time. Other ways that we can help prevent CRS is trying to do what we can to prevent unnecessary use of antibiotics. So we have to reduce antimicrobial use if we want to reduce resistant organisms. And so again, reducing unnecessary use, decreasing the use of higher risk antimicrobials, and shortening the length of antimicrobial courses if possible. So we know that CRS is more common in those who have a history of MDRO infection. So from a clinician standpoint, we'd want to make sure we have the appropriate antimicrobial at the appropriate dose for the appropriate length. And from a nursing standpoint, we want to make sure that we ask for an end date when this is ordered. We don't want to just continue this indefinitely. We want to advocate for switching from IV form to oral form when and if possible. And some other actions that we can take are making sure that we follow infection prevention and control guidelines, encourage vaccinations, having that good communication with other facilities, educating the patients and families about infection prevention and control and about the overuse of antimicrobials. Sometimes patients and families really stress that they want antimicrobials, they expect them. So educating them about the problems with overusing antimicrobials. Making sure that patients are in appropriate isolation, and then, of course, communicating regularly with the treating team about patients who are showing signs of infection or who are receiving antimicrobial treatment. Again, we want to advocate for the removal of any invasive devices as soon as they're no longer needed. Further, we want to make sure that the staff has periodic training to make sure that they're using good technique for hand hygiene and they're wearing PPE correctly. Auditing to make sure that those guidelines and protocols are being followed. Make sure that we have protocols in place for terminal cleaning in rooms that have been occupied by patients or residents with resistant pathogens. And then, of course, working closely with public health. The takeaway points really are this is an emerging pathogen and an urgent health threat. It continues, continue to see increased cases. The resistance is, again, we're seeing more pan resistance, and that it persists in the healthcare environment and is not removed by those typical disinfectants. And that healthcare staff need to be vigilant in following those guidelines to prevent this transmission and the spread of C. auris. That is all I have today, but I am happy to answer any questions.
Any questions for Melissa? The picture of its spread across the United States is always very sobering. So obviously a pathogen that we need to quickly get a handle on. All right. Well, if nobody has any questions, thank you very much, Melissa, for that great presentation. And we will see you all in 2 weeks to talk about croup. Thank you.